Alloimmunization and fetal anemia go hand in hand. This is immunology at its core. I want to spend a good amount of time discussing the physiology, how mom becomes primed to attack baby's blood, and also help you understand why the first pregnancy isn't the problem. Then we'll go through a diagnostic workup showing you how very few people actually have to deal with this because of the number of criteria that have to be met before you do anything about it. Start off with immunology, physiology. Mom starts off antigen negative. And the antigen we're talking about is the rhesus antigen. We'll talk a little bit more about the different types. Suffice to say, in the first trimester labs, you're going to ABO type her as well as determine her rhesus antigen status. Alloimmunization can only happen in an antigen negative mom. That antigen negative mom has never seen the antigen, so considers that antigen foreign. But having never seen that antigen before, she will be antibody negative. She is going to couple with a dad. And in order for this to matter, the dad must be antigen positive. And of course, antibody status of the dad is irrelevant. He has the antigen, and since his body will never see a developing fetus, it's irrelevant. Now, of course, antigen status may be homo or heterozygous. For simplicity, let's just say someone is or is not antigen positive, and their genes is or is not antigen positive, which means that the fetus developed by mom and dad, the baby, is going to be antigen positive because dad passed on the antigen. On this first pregnancy, mom's immune system has never seen the antigen, doesn't know what it is or even that it's foreign. So, recognizes it as foreign now and builds an immune response against that antigen. In this pregnancy, baby is not at risk. In a subsequent pregnancy, mom is still her genes, she's still antigen negative. But now she is antibody positive. She couples with a man, doesn't have to be the same one, but he is antigen positive. Their offspring, the fetus, the baby, will be antigen positive. Only this time, mom's body can recognize that antigen on baby and attack it. It's an immune response that attacks baby's blood, destroys it, leading to fetal anemia. But it's not enough that you have antibodies. You have to have antibodies in sufficient quantity and of the right type. There are 3 antibodies you should learn about, and this advanced organizer helps you remember which one is good and which one is bad. They're L, D, and K. Lewis lives, that is no fetal anemia. Duffy dies, causes fetal anemia, and Cal kills. The only one of real relevance is going to be D. I'll give the punchline away. The treatment for this is ROGAM-D, Rh-D immune globulin, rhesus antigen D immune globulin, to protect against mom ever being primed in the first place. The D is for Duffy. And they must occur in sufficient titers. There has to be enough of them to cause a problem. The titers must be greater than 1 to 8. And remember, this is not a ratio. The bigger the number after the colon, the more antibodies there are. This is not a fraction, not a ratio. Look at the number after the colon. The bigger it is, the higher the titer. So you need the right setup twice, and you need the right kind of antibodies and the right types of antibodies. Let's see how this is actually going to work for a mom. On her first exposure, there's going to be some maternal fetal blood mixing. And that usually happens at the end of pregnancy. Dilation and curettage for an abortion, delivery where there's bleeding, C-section, postpartum hemorrhage involving the placenta. Something causes the blood to mix. Just being in mom isn't enough. So you have to have that maternal fetal mixing. And mom's primary immune response is to build IgM. IgM cannot cross the placenta and affect baby. If you remember, IgM is a pentamer, and it's too big to fit across the placenta. And since this often happens from maternal fetal mixing, which happens later on in pregnancy, even if mom's immune system were to see that antigen, it happens so late that it doesn't matter. Which means that this exposure, this antigen positive baby is not affected, but instead can prime mom's immune system. And this is the basis for giving prophylaxis when the situation occurs. I'll talk more about prophylaxis at the very end. On this second pregnancy, the second exposure, mom's immune system has matured its response to that antigen and has developed IgG. IgG can easily cross the placenta and attacks baby's blood, destroying it, leading to fetal anemia. And every subsequent pregnancy with rhesus antigen positive baby is at risk of having fetal anemia happen. That's the physiology and immunology. Let's talk about the diagnostic workup and in which steps you're going to take to help mom either prevent this from happening or to identify a fetus that's at risk and what you do about it. At the very beginning, your first screening labs, you're going to determine what mom's rhesus antigen status is. If she is antigen positive, she can never develop the antibody because she's already antigen positive. You're done with the screening workup. It doesn't matter anything else because she cannot develop an antibody to her own antigen. But if she's negative, then you have to ask, is the dad Rh antigen positive or not? What is the Rh antigen status of dad? If it is known to be negative, then you can simply stop. If it is known to be negative, baby now can't have the antigen, so can never be exposed, and it doesn't matter what mom's immune status is because baby doesn't have the antigen that mom would attack. If the status of dad is either unknown, the father is unknown or he doesn't know his own blood type, or he is antigen positive, baby's at risk. They may throw this at you. This is not something you should do routinely, but if you don't know but have a high-risk pregnancy, you can do amnio-PCR and determine the status of baby. Don't do that because you're going into the amnion and sucking out fluid. That's kind of dangerous, risk of fetal loss. So in general, that won't happen, but that's a 275 thing. That's one thing you can do if you don't know the father or you don't know the father's status. At this point, there is the possibility that mom can hurt baby because there's a possibility that baby could be antigen positive. So you ask, what is mom's antibody status? Notice the change from AG to AB. And there must be sufficient quantity. So even if mom's antibodies are positive, if they're less than 1 to 8, or they're the wrong kind, they can't do enough harm, you don't have to worry about it. If mom's antibodies are negative, say as the case would be on the first pregnancy, now you want to concern yourself with prophylaxis, preventing alloimmunization from ever happening in the first place. More on that in a minute. But if mom has positive antibodies and sufficient titers, mom is attacking baby's blood. She's got the antibodies, she has the right kind in sufficient quantity, baby is being attacked. The question is it bad enough to really matter? To answer that question, we do a transcranial Doppler. We talked about this at advanced prenatal testing. If the transcranial Doppler does not show increased flow, then even though mom's immune response is targeting baby, it's not bad enough to even consider. If the flow is increased, there is fetal anemia, then you have to make your decision based on gestational age. What's up with the transcranial Doppler? Basically, we assume that the delivery of oxygen is based on the amount of hemoglobin and the cardiac output. If hemoglobin falls in baby, the cardiac output has to increase to compensate. An increased velocity, an increased flow is indicative that baby is trying to compensate for the anemia. It doesn't tell you what the hemoglobin is, it just says, hey, if it's negative, it is sufficiently sensitive to make you not continue the path. If it's positive, you now need to decide, as often we do in obstetrics, is more time in the oven worth it? Fetal demise is the risk of staying in if the anemia worsens. Lung maturation, fetal maturation, is the benefit. And since this is pretty bad and the intervention fairly severe, we tolerate a younger gestational age for fetal anemia than we do most other diseases. That is to say, if baby is over 32 weeks, we say the risk is not worth the benefit and we just deliver. If baby is less than 32 weeks, the development is worth the risk of anemia, and this is where you do the invasive test, the PUBS, percutaneous umbilical blood sampling, where you actually put a catheter into the umbilical vein. We talked about this in advanced prenatal testing. And it also allows you to draw a hemoglobin, so you know it's low, it's confirmatory, and it allows you to transfuse. To review, you have to have the right setup. Mom has to be antigen negative, which she will always be, have had a pregnancy that was Rh positive, developed antibodies at that pregnancy, got pregnant again, now with antibody positive, to a father who is Rh positive, making a baby Rh positive, and then they need to have the right number and kind of antibodies to even consider doing the transcranial Doppler. And if the anemia is bad enough to warrant it, you make your decision based on gestational age, the cutoff being 32 weeks. It would be ideal, however, if you could perform prophylaxis. This is going to be to a mother who is antigen negative and antibody negative, exposed to a baby who is antigen positive. At the time of maternal fetal mixing, which can be any time there is delivery, postpartum hemorrhage, C-section, or any obstetrics procedure, anytime the blood can mix, mom can be primed. To prevent that priming, you will give Rh-D immune globulin at 28 weeks, which is why it's part of the third trimester labs, and within 72 hours of delivery. And delivery could be loosely qualified by any of these things. In this way, you give the immune globulin that binds to baby's antigen, so mom never sees the antigen and never develops the antibodies. A couple talking points, we'll close. In this process, there are really only two tests to use: the transcranial Doppler and the PUBS. We used to use an amniocentesis and a lilograph. That is always the wrong answer. Amniocentesis with PCR to determine baby's Rh status may be an answer at the 275 level, but is probably wrong. You just need to be able to sort out antigen from antibody interpret the transcranial Doppler, and then know that the pubs is the only way you can transfuse. What's most important is finding an Rh antigen negative mom who has an Rh positive baby and give her immune globulin against the D antigen in order to prevent this from happening so that for subsequent pregnancies, you don't even need to concern yourself with this. That is alloimmunization.